Hi there, Leah Gramlich here.
Hi Leah, it's Helen here. How are you? You're very welcome.
Great, nice to hear your voice in person.
You too. You too. Are you all set for today?
I think so. Why don't I just try sharing my screen here?
Yeah, let's do that. I will stop sharing this opening slide and you can try.
Okay, great. And I'm going to share this one. Do you have it there?
Looks good. Looks good.
Okay, and so I'm just going to go into I'll just have it ready to roll. How's that?
Perfect.
Great. How's that? Okay.
Looks great. Thank you, Leah. We'll talk to you soon.
Perfect. And I'll turn off my camera. So Helen, you want me to leave my camera off until like right at the top of the hour once you've introduced me, and then
that sounds good. I'll do the opening address and then I'll welcome you to turn on your camera and your mic, and then I will read out your bio and then ask you to share your screen.
Okay, so I'm going to stop sharing right now, or I'm already stopped sharing.
Great. Thank you, Leah.
Okay, super. Have I stopped sharing? I'm sorry, I don't even
know. You have.
Okay, great. Thank you. Perfect.
Putting up the holding slide there now.
Okay. Nice to meet you in person. I'm going to stop my video and I'll go on mute for a few minutes.
Great. Really looking forward to chatting to you then. Good afternoon, everyone. You're very welcome to today's webinar, and we're just delighted to see people turn out in such high numbers for this International Brain Awareness Week event. I myself am Dr. Helen McMonigal, a Rehabilitation Coordinator for alcohol-related brain injuries, and I'm very happy to be hosting and chairing today's event on behalf of our organisation, Alcohol Forum Ireland. We are a national charity dedicated to working with people, families and communities to reduce the harm caused by alcohol across our society. And within that body of work, we are aware of and actively supporting efforts to highlight and address the harmful impact of alcohol on brain health across the lifespan, including fetal alcohol spectrum disorders, the impact of alcohol on the developing adolescent brain, alcohol-related brain injuries, including Wernicke's-Korsakoff syndrome, which we'll be looking at in the latter half of today's session. For us, there is no health without brain health, and the prevention and early identification of alcohol-related brain harm is a really, really essential component of working towards a brain healthy society, which is why we're so pleased to place this event in National Brain Awareness Week. Now, you might be wondering why address malnutrition as part of National Brain Awareness Week. Well, we all know that malnutrition and the harmful use of alcohol both play a really important role in brain health across all ages. And both of these factors particularly collide when we come to think of a group of conditions known collectively as alcohol-related brain injury or alcohol-related brain damage, as it's referenced to elsewhere. And this is a group of serious neuropsychological, neuropsychiatric conditions that can result from the harm caused to the brain through the excessive use of alcohol and comorbid nutritional deficiencies, principally thiamine deficiency. And when different forms of alcohol-related brain injury arise, they can be both life-threatening in their acute form and, if not effectively treated, can lead to enduring disability. And anybody that has met a person with alcohol-related brain injury will know the impact that this condition can have on the person, the family unit, and the range of gaps that exist within services to meet their needs. And this has spurred in recent times quite a strong drive, largely driven by clinical need on the ground, to resolve these service gaps and to ensure equitable access to neurorehabilitation for people affected. And we all have a role to play in taking every single opportunity that we can to advocate for the development of these really crucial services and to continue to highlight the gaps in these areas. But what we also know alongside that is that what we're working with here is a preventable condition, and working to resolve the factors that drive its development serve as a really, really important part of the equation. It's simply not enough to respond when harm has occurred, and we need to take steps where we can to work towards prevention, and that's an absolute must. We know from the available evidence that approximately 1.4% of the general population will develop one form of alcohol-related brain injury, Wernicke's-Korsakoff syndrome. And this is a condition that is linked inextricably to malnutrition and thiamine deficiency in alcohol use disorder. And the devastating impact and disabling nature of this condition really highlights the need for services to remain very vigilant to high-risk groups and to make routine dialogues and responses around nutritional status and brain health a really core part of their interventions. So looking at today, we'll start by giving a really broad overview of malnutrition as a whole, and that'll be provided by Professor Gramlich, looking at the spectrum of deficiencies that can arise with a particular focus on malnutrition associated with alcohol-related liver disease. We will then narrow into looking more specifically at thiamine deficiency, particularly as it pertains to the risk of Wernicke's encephalopathy, and the really swift responses and high index of suspicion required in those scenarios to really protect and promote brain health in the people that we serve. We'll then move on to looking at how we can have more routine dialogues with people around nutrition and thiamine as part of overall recovery from alcohol use disorders. And we are really pleased today to launch a new resource to support that activity within services. And we'll be looking at that in detail towards the end of our session today. We have a really, really wonderful lineup of speakers here today. Any questions that you have, just pop them into the Q&A box and I will bring them to our speakers' attention after their presentation. We're hoping to be finished up around 3 o'clock today. So in pursuit of that, I will introduce our first speaker, Professor Leah Gramlich, and I'll ask her to kindly turn on her camera and her mic now, and I will welcome her to today's session. Professor Gramlich is a highly distinguished gastroenterologist and physician nutrition specialist with the Royal Alexandra Hospital and a professor of medicine at the University of Alberta. She graduated from the Faculty of Medicine at University of Alberta in 1987 and completed her gastroenterology fellowship there before completing a fellowship in nutrition and metabolism at Harvard University. She has since held many leadership positions, including being the founding president of the Canadian Nutrition Society, a member of the board of directors at the American Society for Parenteral and Enteral Nutrition, and as a chair of the Canadian Malnutrition Task Force. So not surprisingly, and in light of all of that, and in recognition of her contribution and leadership in linking nutritional research and practice, she was in 2018 awarded the prestigious Khurshid Jijiboy Award. Professor Gramlich, absolutely delighted and honoured to have you here today.
Great, thanks for having me, Helen. I'm going to start to share my screen here. You can let me know if you have it.
Will do.
Okay, I'm going to, sorry, and I'll start presenting here. Great. And do you have it there, Helen?
We can see your slides. We just need to go into slideshow, and I think we should be good to go then.
Okay, it's just taking a little while to, sorry.
That's okay.
What about if I do this? Can you see that there?
We can.
Okay. Is it okay if I use this field? I'm having a hard time going into.
Of course. Of course.
Okay, great. You guys, I know we're short on time, so I'm just going to get going. It's great to be here. And I'd like to thank Helen for asking me to present this topic because it really made me think a little bit. So we're going to talk about optimizing nutrition and nutrition care and alcohol use disorder. And I'm going to take you not to 10,000 feet or right to the front line of the practitioner, but to about the mid-height. I've got some disclosures to share with you. But over the next 20 minutes or so, I want to start by leveling the playing field by describing alcohol use disorder, because that's different than alcoholic liver disease. And I had to pivot a little bit. I want this audience to recognize how alcohol can impact both gastrointestinal function and nutritional status through a variety of ways. And then we're going to talk at a high level about nutrition care, because I know we've got expert speakers talking about nutrition and brain health. Let's start with a case study. This is Mr. GG. He went to his primary care physician increasingly frequently with complaints of weakness and weight loss, and he was run down, calling in sick to work repeatedly. And in fact, at the urging of his family, he finally presented to the emergency department with no specific complaints except for weakness and weight loss. He really had no past medical history or surgical history, and he was on no medications, but he had been a heavy alcohol user over many years. He was a former smoker. He quit 18 months prior to presenting to hospital, and he was living with a partner who was also a heavy drinker. He did have long-time stable work as a linesman, and he actually had no issues with food security. From a diet history, he had no appetite. In contrast to living to eat, like most North Americans, he ate to live. He is a milk drinker, that's a positive thing, but he often skipped meals, ate small amounts, And he was drinking his self-described 6 to 8 rum and coke a day, representing probably more than 30% of his caloric intake. If you think that one serving of hard liquor is about 150 calories and 250 mils of coke is about 300 calories. So he was getting quite a few calories. So if we look at him, and what I want to demonstrate here is that he, at 180 centimeters with a usual weight of 75 kilos, had actually lost about more than 10% of his body weight. You can see on physical exam here that although this is a linesman, you know, climbing poles, he's actually got reduction of bulk and tone of his lean tissue. You can see it looks like he doesn't have much fat. His bones are sticking out. He's got temporal wasting. He's not wearing bottom dentures at this time. So he does have subtle features of reduction in lean tissue and fat stores on physical exam, but no stigmata of chronic liver disease. Nutrition features of his alcohol use disorder included anemia with macrocytosis suggestive of B12 or folate deficiency, or simply anemia related to chronic liver disease. His PTINR was elevated at 1.5, suggesting vitamin K deficiency. He was potassium, phosphorus, and magnesium deplete. And potassium and phosphorus are intracellular cations. They love to live in muscle. This suggests reduction in lean tissue stores. His magnesium level, I'm sorry, my photo's in the wrong location, was 0.6, so it was well below the lower limit of normal. On ultrasound, he had no stigmata of cirrhosis, but did have fatty liver. On his liver function test, he had mild hepatitis with an AST and an ALT 2 to 3 times the upper limit of normal. And he had osteoporosis on bone density study. So here's a guy who's been drinking for his whole life. He's 55 and he finally hit the wall. And you wouldn't think he's malnourished looking at him. So let's talk about a few key facts. Worldwide, and this group is not naive to these facts, 3 million deaths every year occur as a result of the harm related to alcohol, and that in fact represents 1 in 20 of all deaths. And in fact, the age group significantly affected by this includes those in the ages of 20 to 39, where it accounts for almost 13% of the mortality. There's clearly a causal relationship between harmful use of alcohol, in addition to its impact on GI health, relative to mental health and behavioral disorders. Beyond health consequences, the harmful use of alcohol brings significant social and economic losses to individuals and society at large. So if we try and drill down on alcohol use disorder, I reflect as a gastroenterologist. We have an inpatient ward at the Royal Alec, and we take care of about 20 to 25 GI patients. And at any one time, at least half of our patients are those with severe alcoholic liver disease. We don't take alcoholic pancreatitis or alcoholic hepatitis. We take the bad encephalopathy, refractory ascites, and it's rife in our hospitals. So to think about putting a label around alcohol use disorder, put our arms around it so I can think about treating that alcohol component, not just the liver component, has been helpful. It's defined as a problematic pattern of alcohol use accompanied by significant impairment or distress. 1 in 7 US adults, but only 7% of affected individuals will actually seek help. Interestingly, men are much more likely to seek help than women for alcohol use disorder. There are simple screening methods that can be used to identify individuals who may be evaluated for alcohol use disorder. And I'm impressed that just over the past 5 years, and I've been in practice for a long time, our treatment paradigms for AUD are evolving. Once again, so we're on the same playing field, I put up some definitions of alcohol use disorder. So binge drinking disorder, for males, it's consumption of more than 5 standard drinks, and for females, consumption of more than 4 standard drinks on the same occasions. Heavy alcohol use is binge drinking on 5 or more days in the past month. So think Friday, Saturday, 4 weeks a month, that takes you to 8 days a month. And alcohol use disorder is this problematic pattern of alcohol use leading to impairment or distress. Mild is you meet more than 2 diagnostic criteria, moderate is 4 to 6 criteria, and severe alcohol use disorder is 7 to 11 criteria. I know this font is small and you're all on your own computers, but I'll give you a moment just to have a look at that. Remember, mild AUD is 2 to 3 criteria, moderate is 4 to 6 criteria, and severe AUD is 7 to 11 criteria. So why is alcohol use disorder and nutritional status? What is the relationship between those two? Well, the major causes of alcohol-related morbidity and mortality within the GI system are the liver, which is the storehouse of energy metabolism. In addition, the pancreas is inordinately impacted by alcohol use, and that's the center for insulin secretion as well as that for digestive enzymes. In addition, alcohol use leads to the development of gastrointestinal cancers. You can't underestimate the impact of alcohol use disorder on mental health and the social determinants of health. And that overlap between mental health and nutrition intake and social determinants of health and nutritional intake is very closely related. So although alcohol-related dysfunction related to the liver and pancreas is common, it can also impact GI mucosa, leading to diarrhea, malabsorption, and other nutrient deficiencies. It's relevant to know that the pattern and type of beverage intake relative to alcohol haven't been consistently shown to predispose to any specific effects. So whether you're a beer drinker, a whiskey drinker, or a wine drinker, doesn't matter. They're all equivalent. I've moved here this slide on nutritional and behavioral health disorders because actually as I survey the environment related to nutritional status and mental health, I actually think it's one of the evolving areas in nutrition science. It's clear that diet and nutrition have a causal role in behavioral health disorders, and that dietary interventions may improve outcomes. It's not actually well studied, and there's a lot of limitations of the research, including difficulty in establishing an evidence base because of the complex, multidimensional nature of behavioral health disorders and the complexity of nutrition science. The one thing that's pretty clear relative to nutrition health and behavioral health disorders is that a well-rounded diet high in fruit and vegetables, low in saturated fats, low in processed meats is probably healthful. Let's look at the GI tract specifically. So within the upper GI tract, the esophagus can be influenced by gastroesophageal reflux disease in the setting of alcohol use disorder. There is an increased risk of gastritis. There is no increased risk of peptic ulcer disease. Let's pause for a minute on the pancreas. So alcohol in Edmonton, Alberta is responsible for about 1 in 2 of our admissions with acute pancreatitis. And in fact, 1 in 10 patients with chronic alcohol use disorder will develop acute pancreatitis. Oftentimes, that's an opportunity for a patient to be admitted to say, alcohol is a problem, let's address it, because the pain associated with that is not inconsequential. With respect to chronic pancreatitis, defined as exocrine and endocrine pancreatic insufficiency, half the time it is related to alcohol, and chronic pancreatitis is associated with significant malabsorption and chronic malnutrition. In the small intestine and colon, once again, you can get diarrhea. It may be associated with worsening symptoms of inflammatory bowel disease. And alcohol is associated with increased risk of GI tract malignancies, including esophagus, gastric, pancreatic, liver, and colon cancer. So clearly alcohol is related to GI tract function and dysfunction. I share this photo of a fellow who was admitted to our unit with alcohol-related pancreatitis. Now, you wouldn't think this fellow looks malnourished. This is 10 days post-admit, but you can see a slight temporal wasting. And he's got squared shoulders. This isn't a great photo, but although this guy is big in terms of BMI, he's actually got evidence of lean tissue and fat loss suggestive of malnutrition. Why is the liver important? It's really important. Think of the liver as the storehouse for energy, metabolism, protein synthesis, and a variety of other key metabolic functions. Alcoholic liver disease is the most prevalent type of chronic liver disease worldwide, irrespective of viral liver disease like hepatitis B and C. Alcoholic liver disease can progress from alcoholic fatty liver to steatohepatitis, where there's inflammation, and chronic steatohepatitis can eventually lead to fibrosis and cirrhosis, and in some cases, hepatocellular cancer. In addition, severe alcoholic steatohepatitis with or without cirrhosis can lead to hepatitis. Now, just pause for a minute here because we're focusing on alcohol, but globally, the prevalence of non-alcoholic fatty liver is advancing at the same rate that obesity is advancing. And if you got one cause of liver disease and you throw in another cause of liver disease, poof, it can grow. So this doesn't address the coexistence of alcoholic liver disease with other liver disease. Most individuals consuming more than 40 grams of alcohol a day are at risk for developing fatty liver from alcohol, and a subset of individuals develop more advanced disease. How do we explain this variation? Genetic, epigenetic, dietary factors may explain inter-individual variability. One thing is clear. The severity of liver disease in patients with alcohol use disorder correlates with the severity of malnutrition. I'll just demonstrate this graphically and walk through you here. So 90 to 100% of alcoholics will have fat in their liver, like we saw in our case presentation. So this is a normal liver. When you get alcoholic fatty liver, it gets big. People might say, oh, I got pain in my right upper quadrant because that capsule gets stretched. You might feel a big liver. Of those 90 to 100% who have a fat or steatosis in the liver, some can develop steatohepatitis, so inflammation in addition to fat, and about 1 in 5 will develop cirrhosis. And in the setting of cirrhosis, 1 to 2% a year will develop hepatocellular CA. Progressive liver disease associated with progressive malnutrition. So what's the epidemiology of alcohol-related malnutrition? With the exception of alcoholic steatosis, so that's no inflammation, malnutrition depends varying on the presence of cirrhosis, and it can be present between 20 to 60% of the time. Individuals without liver disease may be nutritionally normal. They may be deficient in micronutrients, such as this patient we shared, or they can have significant protein calorie malnutrition. And there's no reliable predictors of who will develop malnutrition as a result of moderate to heavy alcohol use. So how do patients with alcohol use disorder get malnourished? Both acute and chronic alcohol consumption can cause malnutrition. In my practice, 9 times out of 10, malnutrition results consequent to reduction in nutrient intake. And I've written caloric intake there, but I should have written nutrient intake, because when I think of nutrients, I think of macronutrients, protein, carbohydrate, and fat, all of which are calorie or energy sources, but I also think of micronutrients, vitamins, minerals, etc. We've talked about how with impaired pancreatic function, you can impair digestion and absorption. With a bad liver, you impair protein synthesis and secretion. You have altered catabolism of gut proteins and increased breakdown and excretion of nutrients. Hemoglobin or blood is an example. The degree of malnutrition depends on the amount of alcohol, the quality of food, genetics, presence and severity of comorbid disease. And if alcohol intake makes up more than 30% of the caloric intake, the risk of developing micro and macronutrient deficiencies increase. So you've got to do a bit of math and you have to ask. So that's graphically depicted here. And the reason I included this picture again, normal liver, you can drink and have a normal liver, but more likely you're going to have steatohepatitis in the setting of alcohol use disorder. If you develop steatohepatitis, inflammation characterized by high AST and ALT, you are more likely to develop fibrosis and cirrhosis, although you can get fibrosis with just fat alone. If you develop cirrhosis, you're at risk for developing hepatocellular CA. with cirrhosis, you end up with this kind of picture: wasting, food challenges because of early satiety from ascites and the complications of end-stage liver disease, such as hepatic encephalopathy. So the other side of alcohol use disorder and nutrition considerations, and I've given you references here. I did some great reading, so thanks to you, Helen, for that. But frankly, these people aren't eating enough. They're not taking energy. They're not taking protein. They're not getting their vitamins. And we're going to hear about thiamine, riboflavin, the B vitamins. But think about folic acid, vitamin A, C, E. Those are vitamins that are prevalent in fruits and vegetables. Vitamin K, important for coagulation and a normal liver function found in green vegetables. Diets are often also deficient in magnesium, selenium, and zinc. The interesting thing that these nutrition deficiencies actually might be complicit in the physical dysfunction, altered body composition, mood disorders, including anxiety and depression, that we observe in alcohol use disorder. So there's some point at which nutrient deficiency contributes to the progression of dysfunction in alcohol use disorder. There is this paradox of increased energy intake. So think of Mr. GG having 6 to 8 rum and cokes a day at 350 calories. That's almost 3,000 calories. But you get to a point where you have a lower fat mass and body mass index than you anticipate based on the alcohol-related energy intake. And that's because you get altered metabolism of alcohol, preferential metabolism, and altered energy metabolism, such that you get risk for malnutrition. These are not calories that are useful calories. In addition, it's important for us to consider that it's not only the ultra thin individual with a BMI of less than 18 or 20 that we need to be looking at. Malnutrition occurs in those with obesity as well. So I work a lot in the area of malnutrition, and malnutrition, I love this definition here: a deficiency in form or function arising from the deficiency of nutrients. Recently, there's been a GLIM consensus definition. The reason I put this up, because you're a varied group of learners here, is that there are etiologic criteria and phenotypic criteria that help us define malnutrition. Etiologic criteria include reduced intake and altered metabolism, both of which are prevalent in AUD. And there are phenotypic criteria: weight loss, low BMI, and physical exam findings of low lean tissue depletion. In hospitalized patients in Canada, we use a screening tool called the Canadian Nutrition Screening Tool. As a gastroenterologist and clinician, these are two really powerful questions that I think you should consider asking. Have you lost weight without trying over the last 6 months? And if the patient has ascites, pay attention to how much that weighs. And have you been eating less than usual over the past 2 weeks? If you answer yes to both those questions, or if your patient does, that is a patient who's at risk. So once again, this is a young fellow with alcoholic hepatitis. You can see he has no fat, no lean tissue. He's got ascites. You can see veins under his skin. That's probably in part related to the fact that he has no fat tissues, and he's got a leaking paracentesis site. So if we want to think about optimizing a nutrition intake in alcohol use disorder and think about food as medicine, we need to consider the fact that although supplementation of vitamins, minerals, and caloric intake are appropriate, these factors are backdrops to behavioral, psychiatric, and pharmacologic treatments in the alcoholic or individual with AUD. It's also important for you, as those taking care of individuals with AUD, to think about the social, environmental, financial, psychological, and medical aspects that are impacting nutrient intake, dysphagia, anorexia, ascites, etc. So I always ask patients what they eat. So I imagine this group is used to asking, oh, what do you drink? How much do you drink? How frequently? I like to ask about eating because I think it helps us identify windows of opportunity. So when do you eat? How much do you eat? What's the composition? How do you improve intake and reduce losses? Is there a role for vitamin supplementation? And can you get that individual to take a multivitamin? What about diet recommendations and priorities? And this is outlined, and I'll share you the reference. So recognizing malnutrition is really important, and particularly physicians who talk to individuals about malnutrition saying, you're malnourished. Physicians our key opinion leaders to raise awareness for an individual or their family about malnutrition. You need to prioritize nutrition care in addition to reducing alcohol intake. Think about including a dietitian, consider the role of family, consider the role of social supports, think about multivitamin, mineral supplementation, the use of oral nutrition supplements. This has been outlined, and this is a reference from that. And there are multiple guidelines, the American Association for the Study of Liver Disease, American Society for Enteral Nutrition, and similar European organizations. This is in cirrhosis, because there's a lot of work in cirrhosis and less work in alcohol use disorder. But in this group, think of the highest risk with an end-stage liver, 30 to 40 calories per kilo, reducing periods of fasting because you've got a compromised energy storehouse. Ensure protein adequacy, 1 to 1.5 grams per kilo of dry weight for the individual. Think about composition of meal and timing. Think about the role of ascites in nutrient intake, a nighttime snack, and think about micronutrient repletion. I put this up here because the vast majority of alcohol use disorder is that we don't want to see them when they're advanced cirrhotics. We want to see them when they're healthy and wise. And so following a pattern of dietary intake that's evidenced by the Irish pyramid here is good. But when I Googled the Irish pyramid, this is what I came across. And I giggled with Helen because there's the meat and potatoes and whiskey, ale, stouts, and everything else. But this is a pattern of healthful dietary intake, more fruit and vegetables, less processed food, whole grains, limited amounts of meats. I share with you the Canadian food guide. Our food guide changed in 2019. We are no longer using portion sizes, but actually a plate. That's the size of your hand, with half as fruit and vegetables, a quarter as low processed meats and meat alternatives for protein, and a quarter as complex whole grains. But these are key messages that are now part of the Canadian food guide. Be mindful of eating habits, taking time to eat, notice when you're hungry and you're full, cooking more often, planning what you eat, involving others in your eating, enjoying food, sharing meals with others. So I think those are important messages, and we learned that from the Brazilian food guide. Consider that when you're counseling patients. Recovery from alcohol use disorder is possible, and improving recovery rates will likely require interventions outside of the healthcare sector to affected communities, within social networks, and using public health approaches. We need to focus on that. I'm going to go back to Mr. Gigi, who is actually my younger brother. I'm the third and he's the fourth of 7 kids. And I'm the sibling who was encouraging him to be abstinent. So he was admitted to hospital, and he actually has now been abstinent for 18 months. So I phoned him, I said, Gord, can I use your picture? And he opted out of formal AUD treatment outside of his hospital stay, and he said, I just needed to quit. You can see that he has no more temporal wasting. His dentures fit. He's back at work. He's back to 175 pounds. And he's got a new life. His appetite is good, and he is eating regularly. So in conclusion, alcohol use disorder has an impact on GI health, mental health, both of which influence nutrition status. Malnutrition is prevalent and worsens with progression of alcoholic liver disease. Cardinal features of malnutrition include weight loss and reduced food intake, and nutritional status should be integral to the management of AUD. And it's a wide spectrum, because in doing this talk, I have siblings who are affected, like I'm sure everyone in the audience does, family members influenced by this. So it's the severe liver disease in the hospital that I take care of, or that in my family members. How do we eat? How do we obviate that? Thank you very much.
Oh, Professor Gramlich, thank you so much. If you maybe wanted to end your screen share there, I will bring you a couple of questions. I'm very conscious, Professor Gramlich, as well, that I made you a very firm promise that I would have you finished up at 7:30 for your 8 o'clock clinic. So we'll just take a couple of questions, but just to say thank you so much. That was very thorough, very thought-provoking, very useful presentation. Done an incredible job with giving us such a comprehensive overview in such a short time frame. A couple of things stood out for me: the severity of malnutrition linked with the severity of liver disease, really concerning one in here in Ireland, especially given a recent study by Beaumont Hospital that has shown a 30% increase in alcohol-related liver disease during the pandemic. So I'd say that here in Ireland, we're seeing rates of malnutrition maybe in excess of what we would anticipate. Just a couple of questions, one in relation to change-resistant drinkers. This person here is seeing the importance of addressing nutritional problems in our work and work with people both in recovery and treatment resistant drinkers, and wanted to ask if there was any particular guidance for working towards better nutritional health in those drinkers that might continue to drink. Any practical guidance would be really helpful.
Yeah, really good questions. And so the in-hospital patient, you guys do not hesitate to use non-formal or formal nutrition support like nasoenteric feeding. If that individual with alcohol use disorder is in hospital, not eating, they've got evidence of malnutrition, think about formal nutrition therapy like nasoenteric feeding. In the individual who's treatment resistant, get a dietitian in the loop who has access to a social worker, someone who can do due diligence to take a diet history, identify the barriers and enablers to nutrition intake, remove social barriers like, get social supports, oral nutrition supplements, meals on wheels. It's the timing, the frequency. I actually think in preparing for this talk, we're missing the mark with mental health and nutrition, and that overlay with mental health and alcohol use disorder nutrition. It's like throwing a match into gasoline or something. We need to pay attention to it. Low-lying fruit, a multivitamin a day, regular, frequent, small meals. Don't rely on the calories associated with alcohol. They are not doing anything. And so when you're paying attention to that, think about the protein that these individuals need. So that's eggs, peanut butter, nuts, cheese, milk products. Protein is really important.
Excellent, thank you. Yeah, treatment resistant drinkers, they do really, they present unique challenges and they have very special requirements and considerations. So thank you for that. The second one in relation to diabetes, and this is a really interesting one because we do see a high rate of incidence of diabetes and Wernicke's-Korsakoff syndrome. And just wondering what are the considerations we can take with the diabetic patient to ensure proper management as early as possible in treatment? Is there a role for a dietitian here?
Oh, absolutely. If you think of that complex, so the diabetic might be a type 2 diabetic who's got obesity and alcohol liver disease and non-alcoholic liver disease. And that's an individual in whom you might not think, oh, they're malnourished because they might have a BMI over 30, for instance. So optimize glycemic control with reasonable strategies. And so in that individual, it's complex. You need a dietitian to help, but to pay attention to protein nutriture, micronutrient nutriture, optimizing glycemic control. So they need help. It's a complex situation, and don't be scared to ask for help. Recognize that that's complex for the patient as well as the healthcare provider. We got to give them the expertise.
Excellent, Leah. Thank you so very much. And I will stop you there and say a very sincere thank you for your time and your expertise here today, which has no doubt been of great value to all of our attendees. And I hope you've enjoyed your time here today as well, Leah.
Thank you so much. And I see there's some questions about, can the slides be presented? You'd be welcome to share them, PDF them and share them, Helen.
Excellent, Leah. Thank you. Appreciate that.
I'm going to join, but I'm just going to stop my video and look forward to the next presenters. Thanks for having me today.
Fantastic. And I've made pages of notes here. And I guess for me, it's recognizing how much we can learn and benefit from the expertise from nutritional perspectives, and would definitely be great to have further events of this kind and maybe training for professionals in this area as well. But moving on swiftly to our next session, which will be directed towards thiamine deficiency specifically, and looking at an acute form of alcohol-related brain injury known as Wernicke's encephalopathy. This is such an important area, given for this condition to have the potential to be both life-threatening and, if not treated properly, causing disability and brain injury in the long run. I'd like to welcome Dr. Jouahar and ask him to join us here today. If you'd like to turn on your camera and your mic now. Dr. Jouahar is a consultant liaison psychiatrist with the Royal Derby Hospital in the UK. He has both qualifications qualifications and experience in both addictions and neuropsychiatry. He has a particular interest in alcohol-related brain injury, a really under-recognised public health issue that falls into commissioning gaps here in England and indeed in the Republic of Ireland as well. Dr. Joaher, you're most welcome.
Thank you very much. I'll just get my slide.
Thank you.
Right, I think hopefully everyone can see that. Right, so I'm Carter Jauhas. I'm a consultant liaison psychiatrist. So thank you for asking me over to speak about this topic. What I'm going to try and do is teach everyone what they need to know about Wernicke's in about 8 minutes, really, because it's when you know a little bit more about it, you realize that it's under-recognized and you should treat it, basically. And there is a lot of harm that can be done if you miss it and you don't treat it, but there's not much harm to be done if you treat it and actually it wasn't there. And so from a public health perspective, I think we need to think about that. We're going to talk about thiamine and why it's important, specifically to what happened in Wernicke's, and that will tell us why it happened. We're going to talk about what it's going to look like, and then how are we going to treat it. And finally, what happens if you don't? What happens with the accumulated brain injury that you can acquire from dependent drinking, which is where we stray into the realms of Korsakoff syndrome. So first of all, let's just have a think about thiamine. Now, it's vitamin B1. It's a micronutrient. Now, humans are dependent on exogenous sources, so we can't synthesize this in our own bodies. So we need external intake for our body to do its thing. It has a lot of different functions. The bit that I want you to just understand is a key link in metabolism and how our cells power themselves. Specifically in brain health, we're looking at oxidative metabolism, and your midbrain, which is our kind of primordial brain, which we kind of share with other animals on the planet, needs it, and then our cerebellum, which is at the back and is mostly used about fine motor coordination, needs it especially. The dependent drinker is going to have some problems when you think that thiamine is typically absorbed in your gut, and your stores are largely limited because they're protein bound. So you need a functioning liver to synthesize proteins like albumin for the thiamine to bind to, so that you have stores. You need a functioning gut so that you can absorb it correctly. And even if you have all of that, you've probably only got about 18 days worth. It's just not something that our body stores lots of. So independent drinkers, nutrition is already poor. We've just had a very clear session on why that is the case. Absorption tends to be less efficient. And if they're already down the realms of alcoholic liver disease, they're not even going to be able to store much. So it's quite a risk. If you end up in those acute deficient states, you're going to get indirect neuronal cell death. Your brain cells will die, and that is where Wernicke's encephalopathy comes in. This is Carl Wernicke. He's lent his name to this condition. I think it's always worrying when conditions persist with the eponymous syndrome, because it often means that we still haven't learned more about it or how to deal with it, but it still persists. So let's talk about Wernicke's encephalopathy. We think about what I said, this is what's going to happen. So you've got a thiamine deficiency. This is going to make your TCA cycle less efficient. Your TCA cycle is the Krebs cycle. It's what creates energy from within your cells. And if you do that in the brain, you're going to get edema. Now that is both cytotoxic, where your poor metabolism is meaning there are intermediate metabolites that accumulate, which are problematic. That's going to cause vasogenic problems. It's going to destabilize your blood-brain barrier, and it's going to let all sorts in and out that shouldn't be going in and out. And you get this edema, and that is what leads to the indirect neuronal cell death. And it tends to like your midbrain, and it also tends to like the types of cells that form your cerebellum, the Purkinje cells. And this is what gives us the picture that we see in acute Wernicke's. So we'll talk about what it looks like. Just before I do, on the right-hand side, these are MRI flare sequences. In C, there's you got lit up dots in the middle either side. That's in the medial thalamic region, and then you've also got it towards the back or the bottom of the picture. There's the periaqueductal grey area. In D, again in the middle, you've got some lit up areas. That's the mammillary bodies. Now, These are findings that you can have on an MRI scan if you are scanning somebody and they end up having Wernicke's. What I would suggest is that if you're not already treating this patient, then your management is wrong, because you should only go down the route of scanning them if you're looking for other stuff as well, or you're looking to confirm something that you're already treating. It's an acute neurological disorder that arises from the thiamine deficiency that I've just described. You're going to see it in alcohol dependence, but not always. It's to do with thiamine deficiency, isn't it? So what else is going to cause thiamine deficiency? Just to give you some idea, you could have already had some abdominal surgery and you have a short gut, so you malabsorb. You could be undergoing chemotherapy and you develop acute Wernicke's. If you're pregnant, you could be having hyperemesis gravidarum. They can also develop acute Wernicke's, but about 60% of Wernicke's is alcohol related. The classic triad that you see in textbooks is this: so ophthalmoplegia, namely eye signs. There's something wrong with the person's eyes when you look at it. Ataxia, a difficulty walking, and then confusion. But what I wanted to point out, 10% present this way. Okay, only 10%. It's often just confusion that you pick up. It's underdiagnosed as a result. There are some difficulties with the validity of the post-mortem studies, but some of them are pretty harrowing, suggesting that we miss 80% of this diagnosis. So I would suggest, if you are involved in the care of someone who's a dependent drinker and they're presenting to you with acute confusion, they need treatment, and the treatment is presumptive, and in England at least, they need to come into an acute hospital. So if the dependent drinker turns up to where I work and they're acutely confused, you treat as Wernicke's. If you've got any inclination that they might be confused or off their baseline, you treat as Wernicke's until you can prove otherwise. And then that kind of comes on to the treatment. What is it? We already know that we have to treat, and we have to have a low threshold for treatment because it's so easily missed. It's high dose parenteral thiamine. So we tend to use Pabrinex over here in England. It's not just thiamine, it's got some other stuff in it as well. And you're going to go for at least 5 days. Often you might need considerably more. It depends how much brain damage the person already has, and therefore how long does this acute confusion persist. But you're going to need Pabrinex, typically IV. You can give it IM, but it's really painful, and the absorption's not as great. So it's going to have to be intravenous. They've often, if they are drinkers, they're probably dependent drinkers. They're going to need medically assisted withdrawal as well. Symptom triggered if you can, but that depends on the resources that you have available. You're going to have a supportive environment to manage the confusion in a non-pharmacological way, as you would approach any delirium. And if you are right in your diagnosis and your treatment is on board, what we tend to find is that your ophthalmological signs disappear within hours. The ataxia goes within a few days. The confusion may take much longer, up to several weeks. Often you then go to oral supplementation afterwards. This is the excerpt that we have from our NICE guidance from 2017. I think all I'd want you to take away from this slide, which will be circulated afterwards, is that they are very keen for you to treat and to give prophylactic medications in pretty much every scenario that you find the confused dependent drinker. And that is what NICE wants you to take away, and what I'd like you to take away as well. And then finally, if you don't treat and there's repeated bouts of it, or there's other insults that are arising from chronic alcohol use, you're going to meet Sergei Korsakov, and you're going to head into Korsakov syndrome. I'm not going to go into the ins and outs of it, but this is an irreversible form of alcohol-related brain damage. That acute Wernicke's, that scan I showed you, if you treated it and you got the diagnosis correct and you rescanned them, there's no more lesions that you pick up. Korsakov, the lesions remain and the disability remains. I just want to show you this. Some anonymized slices from a patient of mine from about 6 months ago. So on the left, I've got flare sagittal sequence. What you can see with the cerebellum along the bottom is you've got these deep indentations. So that's the atrophy. It should be like this, but it's not. And then what you can see in the rest of the cerebrum is gaps, which there shouldn't be. And the corpus callosum is also degenerating. Now, this person's only 55. This is really bad. And on the right-hand side is T1. You've got some white in the basal ganglia. So they were also encephalopathic. These are depositions of minerals that you see in hepatic encephalopathy. My neuroradiology colleagues are pretty they're pretty, they don't give much away. They don't really say much when I asked them for their opinion on things, but they told me that this is the worst brain they've ever seen in someone of that age. And that is what you risk if you don't treat. And so that's why we've got to treat. That's your whistle-stop tour, your 8 minutes on Wernicke's encephalopathy. Definitely you can contact me on this email address, or get me on Twitter if you want a more candid view. But I'm sure we probably have some time for a few questions.
Excellent. Thank you, Dr. Jawahar. You've entered your screen there. Excellent. Thank you so much. And again, within such a limited time, you've provided so many of the essentials around this. Couple of questions in relation to that, Dr. Jawahar. Firstly, someone has asked here, is 3 days of Pabernex enough?
No, 5. Even the NICE guidelines say 5 if you think it's Wernicke's. Normally, hospital guidelines tend to have a prophylactic and a treatment pathway. More so, nothing gets missed. But certainly, just the way that my service works, these people will get referred to us, and we often extend the Pabernex course if it's not already been extended.
Great. And what do we know about how well we're following the NICE guidance in our acute hospitals at the moment?
It's a good question. I don't think there have been particular national audits looking at that in a lot of detail from a performance management perspective. It is more widely understood now that there is a very low threshold to give loads of Pabernex. Previously, when the first formulations came out of these parenteral vitamins, there was a much higher risk of things like anaphylaxis. So people were worried to use them, but it doesn't really happen with Pabernex, but still it is there, and so it has to be given in an environment where you can account for an anaphylactic reaction. But I think we can do better for sure. Absolutely.
And just from your perspective as well, obviously you have a very unique perspective being in a clinical liaison psychiatry role. You know, assuming that we've got things right from a thiamine perspective, what would be your recommendation around further assessments or interventions that might need to happen before a person leaves the hospital, just so that we get a really full sense of what their psychosocial needs are likely to be?
Yeah, a lot of it is down to the history. So if this person hasn't really got cognitive impairment, and is one of the questions in the chat, if they've not got progressive cognitive and functional decline, which is the definition of a dementia syndrome, then you have to treat this as acute, which means you have to aim to get them back to where they were. The baseline assumption is that you can get them back to their baseline. So we wouldn't really be looking to discharge them until we've gotten them back to their baseline. And if we can't get them back to the baseline, we need to look again because we've missed something as to why they're not getting back to it. Then when they're back to their baseline, we can look to see what extra support do they need. In my service, obviously we're a mental health liaison service, but we cover substance misuse, so we've got our fingers in those pies so that we can access those sorts of services. But we also depend heavily on our social care colleagues, our hospital social care team, if there are other issues that we need to consider. Sometimes if there is persistent confusion, because it can take several weeks, but we're going in the right direction, we might try to discharge them to an assessment bed, assuming one's available, to allow a further period for that confusion to lift more, so that we're accurately assessing what the person's difficulties are, rather than perhaps an artificially high estimation of what those things are in the acute setting.
Excellent. And could you tell us maybe broadly overall, what are the recovery rates for alcohol-related brain injuries or Wernicke's-Korsakoff syndrome? What's the prognosis like for long term?
Yeah, so the main reason why I think this is a bee in my bonnet is anything on the alcohol-related brain injury spectrum, which is basically a little bit of persistent cognitive impairment, full-blown acute Wernicke's, or suspected irreversible Korsakoffs. If you've got if you've got a drinker who becomes abstinent, 75% of them will improve their cognition, unless you've already gone to the irreversible Korsakoff route. And of this 75%, the majority is full, complete recovery. So I'm very careful not to write people off on what I see, because they're snapshots. But we try to be as comprehensive as possible, so that if we catch them again, we've at least got some sort of longitudinal view on the picture. One of the difficulties is the commissioning gap that these patients fall into, because they are viewed as substance misuse in England, which doesn't necessarily have the expertise. they're not going to be able to afford neuropsychiatry input, for example. It's just not how public health is commissioned. And then the corollary of that is in mental health services or neurology. They may be able to help you with a diagnosis, but maybe not ongoing management because they're not commissioned to. And that is a difficulty, which is why we try to do as much as we can for patients who come to the acute hospital.
Excellent, and very reflective of the situation here in the Republic of Ireland as well. And it really is, I suppose, it underpins the need for the development of specialist neurorehabilitation services for this condition. But Dr. Jawahir, great to have you here today. An excellent contribution, as I knew it would be. And thank you so much for giving so freely of your time this afternoon.
Great, no problem. Thank you.
Lovely. Just taking a quick look at the time here, I think we'll move on to our next session today. A lot to take in so far in a very short period of time, but what we have seen to this point is that addressing malnutrition, creating opportunities for optimizing nutrition and preventing neurological harm can be part and parcel of our wider efforts to support people with alcohol use disorder. In this particular piece of the session, we are going to launch a new resource today to support nutrition, thiamine, brain health in our work with alcohol use disorders. And this was really spurred by our own practices and working with people who might have higher risk profiles for thiamine deficiency and having nothing or little in the way of those of resources to support those important conversations about the importance of thiamine and good nutritional and dietary practices. We're very lucky to have the input of our next speaker in filling that resource gap. And I'd like to welcome her here now. Elaine, if you would join us maybe, if you'd like to turn on your camera and your mic.
Can you hear me?
We can, Elaine, you're very welcome. I'll just give our viewers a quick overview. Elaine is a clinical dietitian in the acute setting, and she has been for the last 20 years. She's a graduate of Dublin Institute of Technology and Trinity College Dublin, and a member of the Irish Nutrition and Dietetic Institute. She specialises in gastroenterology at Tala University Hospital and lectures on the GI nutrition course for the MSc Dietetics course in the University of Limerick. With her team, she has won awards for her initiatives to reduce gastroenterology waiting lists and improve care for all of those with functional GI disorders. She's an active member of the Gastroenterology and Hepatology National Clinical Programme Nutrition Subcommittee, which is developing integrated care pathways for patients with chronic GI conditions. She has co-authored and recently updated the hepatology guidelines within the INDI reference manual and has a keen interest in early intervention lifestyle programs to prevent progression to liver disease in at-risk groups. Elaine, you're most welcome.
Thank you, Helen. I'd like to thank Alcohol Forum Ireland for inviting me to speak today and for the opportunity to be involved in this project from the very beginning. We're here for a very important reason, and that is to launch a new resource called Thiamine, Healthy Eating and You, that we hope raises awareness of and helps prevent AORBIs in this country. And as a dietitian, it's been a pleasure to work on this because here nutrition has the potential to change the trajectory of people's lives and their futures. And the launch coinciding with Brain Week emphasizes the risks of sustained excess alcohol consumption. And we've heard from the previous speakers who gave an excellent overview on why nutrition, and in particular thiamine, are critical in the prevention and treatment of brain injury. But what does that look like in practice? And how do we ensure that level of nutrition? And what are we asking those at risk of AORBI to do in food terms? So for my 10 minutes, I would like to take you through the resource, and I'm going to briefly point out the main features of it. The title conveys our priority, and that is to inform readers that getting thiamine through a daily balanced diet can prevent alcohol-related brain injuries. And I want to say from the outset that treatment of malnutrition, refeeding syndrome, and acute management of AORBIs was outside the scope of this resource, and so it's not suitable for these scenarios. And the tone and design of the resource were chosen to reflect warmth and nourishment. Our opening pages connect the dots between brain health and nutrition to help readers make an informed decision and to give impotence to change. We explain here that thiamine is essential, it must be taken every day, and that low levels are very common in those who drink excessively. We know up to 80% of heavy drinkers have a deficiency in thiamine. And as the other speakers have explained, the reasons for this are twofold: poor dietary intake due to displacement of nutrition by alcohol, or from the symptoms of malnutrition such as anorexia, and also the inhibitory effect of alcohol on absorption. And that thiamine deficiency can cause ARVI. We list the consequences here in the resource, but explain that it can be prevented if action is taken. And we invite the readers to learn more at askaboutalcohol.ie. It's very important for all healthcare professionals to recognise the signs of alcohol-related brain injury and report concerns to the appropriate member of their team. Following on from that, we were quite keen to guide readers through some self-assessment tools to identify the level of risk if it's present. So we used some targeted questions such as current level of drinking and food intake. And the more that the reader ticks, the higher the risk. Due to the prevalence of nutrition deficiencies, I'd like to reiterate that anyone presenting with a history of alcohol excess should undergo nutritional screening with referral to a dietitian if warranted. If brain health or nutritional status hasn't been broached before, I would say that this should be discussed sensitively. There may be some more preparatory work to do at this junction. It's at this point of the resource that people have the choice to acknowledge the risks that are being reflected and or take action with the support of family, their carers, and healthcare professionals. We're using words in the resource that might be worrying or frightening, such as high risk, brain injury, malnutrition. So be mindful of that when using the resource. And we continue by addressing why eating well is important, not only in the context of getting thiamine, but in giving the person the physical strength to recover. We continue with, sorry, I need to go back a slide. Sorry, here we are. We continue with more self-assessment by laying out the well-documented signs of malnutrition. Some of these are more specific to low thiamine, such as feeling down, memory loss, blurred vision, shortness of breath, and changes to heart rate. And these signs and symptoms are broad. There's a lot of crossover, and the list is by no means definitive. The aim here is to get the readers or carers to check this list, to detect the signs early and to seek medical attention. The resource, as you can see, it uses a questioning format throughout in anticipation of what the reader might want to know, like what can I do to improve my thiamine levels or prevent deficiency? So as the other speakers have mentioned, the number one and probably most challenging way to maintain or improve thiamine levels is to make changes to alcohol use. And some studies suggest that thiamine levels rise within 6 weeks of alcohol cessation with positive effects on appetite. Evidence also suggests that, as in other deficiencies, absorption is increased if levels are low, which paves the way for quick resolution in the absence of alcohol. And importantly here in the resource, we stress it's never too late to change and to reach out for support. So we've included the details for the HSC Drug and Alcohol Helpline. The reduction or changes in alcohol should be done gradually under medical supervision, as we know that sudden changes may worsen alcohol withdrawal symptoms and increase risk of seizure, which is potentially life-threatening. So we explain that if your levels of thiamine are low, there are probably 3 ways that you can improve that, as well as changing your alcohol intake. So we explain if you're eating normal quantities after making changes to your alcohol, you would likely get enough thiamine from your diet. But if a poor appetite continues, you may require thiamine tablets in a supplement form, and that is to ensure that you get the correct dose daily while your dietary intake is improving. If you require thiamine fast, or if alcohol is continued, you may be given thiamine through injection or IV, as explained by Dr. Jawahar. Next, we reflect on reader expectations. So we ask, what is it you would like to achieve? And the readers can tick all that apply. So I would like to be healthy, have more energy, feel in control, break old habits, or reduce my chances of getting sick. And this is to focus the readers' minds, to reflect the pros of making a change, and to motivate and encourage implementation. Moving on, we included a table here for our readers to benchmark themselves against healthy eating requirements. Again, we're using objective self-assessment to keep the reader engaged and as an active participant in their health. So we take a systematic look through the food groups of the food pyramid, and we ask readers to jot down their preferences from each section, find any deficits, and that brings an awareness and breaks it down into small chunks. As an aside, we were quite cognizant of the reality that the basic principles of eating and meeting these nutritional targets are not so basic for some. So as mentioned earlier in the presentations, issues such as how should I eat, what should I eat, how much will this cost me, they all need to be considered. And this meant a difference in the way we designed this resource. There are many barriers to putting a meal together and reasons why people may not be able to progress to a better quality diet. Including but not limited to heavy use of alcohol, comprehension, finances, safe shelter, mobility, literacy, and access to cooking facilities. And this is something that healthcare professionals, in particular dietitians, are trained to look for and consider when putting nutrition care plans in place. So we included information to answer some of those questions, such as how to eat. Yes, there are challenges in appetite regulation and changes in metabolism due to alcohol excess. There may be a period of appetite retraining, learning what is a normal eating pattern or portion size after a considerable time of poorer habits. And malnutrition itself may impede a person's ability to resist alcohol and recover due to its effect on fatigue and mood and cravings, all of which have to be managed at the same time. So we suggest eating by the clock to overcome this. It's one decision less to be made, and eventually appetite will return with perseverance and consistency. But it needs a supportive environment, perhaps setting alarms, reminders, and that may help. So the barriers and limitations that I mentioned earlier informed our approach to meal planning. In this meal plan that's included in the resource, we chose simple, easy available, low cost, low preparation and portable meals, also rich in thiamine. And in the resource, we've included icons for any equipment needed to prepare these meals, but we've included at least one option per mealtime that requires no heating or equipment. And we suggest useful tips such as hanging onto reusable cutlery if you're eating on the go. These meals may not be perfect, but they're a starting point. It's individualized where we give readers an element of choice, and it shows the readers how they can meet their needs their way. And it can also be used as a monitoring tool by family and friends and healthcare professionals, so it can be shared with others and built on over time. And diet is a way of eating. It's a long-term change, so the reader's going to have more success if small realistic changes are made over time. This resource can be used by anyone on their journey towards better nutrition after a period of sustained alcohol excess. However, as I mentioned earlier, there may be times where people may need more specialized nutrition advice, for example, in the treatment of malnutrition, Wernicke encephalopathy, or if alcohol has damaged other vital organs, such as the liver or pancreas, which may be causing diabetes or pancreatitis. And a dietitian can help with this. And we've included a paragraph about who we are, how you can contact us and access our services. We've also included contact details in the resource for the HSE-led Healthy Food Made Easy program. This is a 6-week basic cooking program for anyone looking to improve their food prep or cooking skills. So I would like to congratulate all the team at Alcohol Forum Ireland for keeping the issue of nutrition and alcohol-related brain injury prevention on the agenda, and to thank all the collaborators and the Loretto Foundation Fund for contributing to and supporting this publication. It speaks volumes to have such a large and diverse audience with us today, and we hope you find this resource useful and you'll take these important messages back to your own field and promote in your daily practice. Thank you very much for listening.
Thank you so much, Elaine. Just delighted to see this resource up and out there. And as I said, this was something that was very much spurred by direct need in working with clients, and not having a nutrition background myself, which a lot of people working in the alcohol sphere maybe don't. It's great to be guided by a specialist dietitian like yourself through the development of the resource, and then also guided through its use here today. You know, from having had it in my hands for the last few days. Like, I mean, I do find it just highly practical, very usable, can be used as a self-directed resource, a supported intervention with a practitioner as well. So we're absolutely delighted with it. A couple of questions here for you. Any particular age groups that this can be directed towards? Can it be used with younger people who might be accessing services for problems with alcohol, teenagers, for example, or older people?
Yes, I think this can be used for anybody over, the age of 16. So it would follow the healthy eating guidelines here in Ireland. So as you said, it's very practical, and I think it's quite easy to use. It's quite self-explanatory.
Yeah, absolutely. And just the second question here, any tips on helping clients who might already have cognitive impairment improve their nutrition? So any particular technologies or resources that could be used to support this as an intervention?
Yes, that's very challenging, especially if the person is living alone. It would depend a lot on the level of impairment, of course. There's lots of ways to improve intake. It's very important to have a supportive environment, of course, and peer example is important. So eating is a very social activity. You may have to encourage adapted meal times and surroundings. But in relation to your question or the question on technology, this is very topical. I suppose there's been a lot in the news about adherence, particularly in relation to medication. A lot of articles in the media, and in nutrition, similarly, apps are being developed to help with adherence. I would suggest simple tips such as setting phone alarms so that the person can remember their eating time, their snack time, and that would keep them to their nutrition care plan. If the person has access to Alexa or Siri, that type of technology, that could also be used. And a step on from that, I suppose, robots are coming. So there are some robots that can be used in the home setting, such as there's one called Milo Connect, which can be rented. I think it's about €9 per day. And Milo would give visual prompts, personalized cues, and use reminders, photo reminders and video reminders, which might be useful to some people, and that would keep the user to their schedule and to follow their routine.
Excellent, Elaine, thank you. And can you tell us a little bit more about the Healthy Food Made Easy course? It's not something that I was aware of, and perhaps others in the field might not be aware of it either.
Yeah, so it's a 6-week, as I said, a basic cooking and nutrition course. So it teaches anybody who would like to improve their cooking skills about the importance of healthy eating. So it teaches you about the food pyramids I've gone through there, and very basic cooking skills. And there is a website, and you can check your own county to see where the courses are running. Sometimes they're done through the local library, but all the information is on the Healthy Food Made Easy website, as we've mentioned in the resource.
Excellent. Thank you, Elaine. And sincere thanks for all of your input with the resource and its development. And I extend my thanks on behalf of everyone at Alcohol Forum Ireland. We couldn't have done it without you. And I have no doubt that it will be of huge benefit for other practitioners and service users all around the country. For anybody looking for a copy of the resource, you can get it on www.alcoholforum.org/thiamine. And that brings us to the end of today's webinar, slightly over our allocated time, but thank you very much to everyone who has joined us here today from all around the world, and in really high numbers as well. I'll be in contact next week with a post-event circular, which will include all of today's slides, a link to the resource, and a link to a recording of this event for any colleagues that didn't manage to make it today. So a particular thank you to the Loretto Foundation Foundation for their support in this area. We are so grateful for their support, and that of all of our funders who without we couldn't do the work that we do to support people and families impacted by alcohol related brain harm. And again, big thank you to all of our speakers who, as I said, had given freely of their time to talk through their expertise today. And lastly, just a big thank you to all of you for turning out in such numbers and providing such thought-provoking questions and comments. Any that we haven't got to today, I will try to address as part of the post-event circular, so keep an eye out for that. But in the meantime, I wish you all a good week, and you can address any comments or areas of interest for future webinars to myself at helen@alcoholforum.org or to our organisation directly at info@alcoholforum.org. And with that, we will end there for today, and I wish everybody a good day. Thank you. Thanks, Elaine. Thanks, Leah.